So let's wrap up our immunosuppressants. Let's review the mechanism of mTOR inhibitors. Notice that it engages some familiar intermediates. The FK binding protein, which is obviously interacting with tacrolimus, is also a place of intersection with your mTOR inhibitors. But instead of modulating the NFAT transcription pathway, which we reviewed with our calcineurin inhibitors, right? Nuclear factor of activated T cell, NFAT. This intersects with cell cycle suppression or engage or progression. Okay, so I remember I told you mTOR is an old pathway that is used by multiple different organisms to determine whether the environment is one of feast or famine, and then tells the cell to either become quiescent or multiply. Okay, and so that's in broad strokes what the mTOR pathway regulates. Okay, and of course, that would make sense that that could be a push point in immunosuppression. Okay, the pharmacokinetics of the available mTOR inhibitors is provided here. The main mTOR inhibitors that are used in transplant are sirolimus and everolimus. Maybe you can intuit that if this is modulating cell cycle progression, you might be aware that mTOR inhibitors are also used in cancer therapy. So especially in, for instance, renal cell carcinoma therapies, you'll find mTOR inhibitors. Okay. Sirolimus was the first generation of this target of rapamycin inhibitor. And everolimus was a second generation or later evolution. Okay, these are both highly protein bound. You can notice that they also interact with similar clearance pathways that we discussed with the calcineurin inhibitors, right? CYP3A4 is common to both tacrolimus and cyclosporin. I hope you remember that cyclosporin is unique in inhibiting P-glycoprotein, which makes it unique and predisposed to more interactions with, for instance, mycophenolate. We talked about how mycophenolate exposure when combined with cyclosporin is less because cyclosporin inhibits that enterohepatic recirculation that occurs through P-glycoprotein mediated drug clearance. Okay, but predicting or knowing this principle will predict that you'll have many of the same drug interactions. That is to say, if I have a P450 enzyme system inducer or inhibitor, you would predict that you need to make the same dose adjustments for your mTOR inhibitors. Okay, so I don't have to repeat that. You can just sort of translate knowledge from what we discussed on calcineurin inhibitors over to the drug interactions with the mTOR inhibitors. Liver disease, similar to calcineurin inhibitors, would raise drug levels of mTOR inhibitors because, again, it's dependent on clearance mechanisms through the cytochrome P450 enzymes. Hypoalbuminemia would presumably increase free drug levels in a drug that's highly protein bound. And again, similar to your calcineurin inhibitors, there's no dose adjustment for renal insufficiency. Okay. Cyclosporin plus mTOR inhibitors are generally a combination you should avoid. When mTOR inhibitors were first introduced on the scene, there was a transplant surgeon from UT Houston who was the primary lead investigator in bringing sirolimus to the clinical realm. And he did studies, I'm blanking on his name, he did studies on combining sirolimus plus cyclosporin. And there were a lot of negative outcomes that were noticed in those original trials, okay? The presumption is that the co-administration of cyclosporin and mTOR inhibitor is a particularly nephrotoxic one, increasing cyclosporin levels, perhaps increasing proximal tubular internalization of some of the nephrotoxic, maybe internalization is the wrong word, increasing calcineurin exposure to proximal tubular epithelial cells, the co-administration and the nephrotoxic insults, okay? So if you're going to use mTOR inhibitors with a calcineurin inhibitor, tacrolimus is your drug of choice. That being said, most often when we're using mTOR inhibitor, it's not to substitute for the antimetabolite. So you don't typically go FK, sirolimus, steroids. Usually the mTOR inhibitor is used to spare the calcineurin inhibitor and the nephrotoxicity from that. A classic scenario you might see is in heart transplant patients who are getting progressive renal insufficiency on tacrolimus. They're switched from tacrolimus over to sirolimus or everolimus, okay? So we often use it as a calcineurin sparing agent. Sirolimus has a very long half-life, okay? And, it has some of the characteristics that drugs with a long half-life you hopefully recall have. So if you have a drug that takes forever to get to 3 half-lives and therefore steady state, we're often giving loading doses of those medicines in order to achieve those steady state levels that are in the therapeutic range. So that is, again, a characteristic of any drug with a very long half-life. Okay, so you'll give a loading dose and then maintenance dosing. Typical doses is somewhere between 2 and 5 milligrams per day. Drug levels are, again, institutional specific. Here's some guidelines of 15 to 30. If you're not giving it with a calcineurin inhibitor, a 5 to 12. When combined with a calcineurin inhibitor, some might use sort of add the FK level plus the sirolimus level, and it should be somewhere in this 15 to 30 range. Some people use that as a guidance, okay? Everolimus, because it doesn't have a long half-life like sirolimus, you give it twice daily. Sirolimus, you don't have to give twice daily because it's a very long half-life. And you don't have to give it with a loading dose. Some typical trough levels that we'll see is somewhere around 3 to 8, okay? These drugs are very difficult to take, especially sirolimus. If you look at some of the conversion studies of taking someone off of tacrolimus and putting them on sirolimus, there's a very high dropout rate to those patients who are converted to sirolimus. There's a very long list of potential side effects, okay? Perhaps these side effects are less common with everolimus. However, there's not been a head-to-head comparison between the two. We've talked about the synergistic nephrotoxicity with calcineurin inhibitors with an emphasis of cyclosporin combinations being especially problematic. Some of the others to be aware of is proteinuria, okay? Let me take a pause and give you a mental model that you can use for understanding proteinuria, peripheral edema, and third spacing of fluids with mTOR inhibitors and other drugs that engage with the VEGF pathway, okay? Let me give you the conclusion up front, develop it, and then repeat the conclusion. So anything that you can perceive in your mind as inhibiting VEGF, normal VEGF signaling, might have a shared phenotype of high blood pressure, edema, proteinuria, okay? What are some examples of that? mTOR inhibitors seem to inhibit pathways downstream of VEGF. Okay. Avastin or bevacizumab, a drug used in oncology, can cause hypertension, edema, and proteinuria. Okay. Preeclampsia. Preeclampsia seems to involve a circulating soluble receptor called FLT, which basically competes for VEGF at its receptor. So it binds VEGF, making VEGF unable to interact fully with its VEGF receptor. How does preeclampsia look? Edema, proteinuria, accelerating hypertension. Okay? There are tyrosine kinase inhibitors, again, used in oncology, that are downstream of VEGF. So as a class, tyrosine kinase inhibitors can cause proteinuria, hypertension, accelerating or edema, okay? Third spacing of fluid as well, right? Not every tyrosine kinase inhibitor does that, but some tyrosine kinase inhibitors, remember, tyrosine kinase is an adapter pathway, right? You have a molecule hit its receptor, and then that signal is transduced in the cell, okay? Tyrosine kinase is an intermediate in that pathway. There are some tyrosine kinases that are more specific for epidermal growth factor. For second-year fellows, you would predict magnesium wasting in those drugs, okay? There are other tyrosine kinase inhibitors that have more specificity for pathways that are downstream of VEGF. And so those would have more of this predilection for hypertension, edema, and proteinuria, okay? So again, sirolimus can antagonize VEGF pathways. That is why it has some anti-neoplastic effects. That is why it predisposes to impaired wound healing. Okay, perhaps. That is why it can be used for blanking, it'll come to me. Biliary angiomatosis, the more esoteric thing came to mind. It'll come to me. So a neoplasm of capillaries, essentially Kaposi sarcoma, right? It is effective against Kaposi sarcoma, right? Antagonizing VEGF, which is a malignancy of basically blood vessels, okay? Microvascular blood, microvasculature, okay? Moving on, mouth ulcers, again, poor wound healing. Often it's not used immediately post-transplant because of a risk of dehiscence. Acne, you can think of this as a third spacing of fluid, lymphocyls. We've talked about peripheral edema. You can have pleural effusions, pericardial effusions. Okay, again, think of that, at least I think of that as more of a manifestation of VEGF antagonism. Cytopenias, okay, severe hypertriglyceridemia. I mean, at the levels that may cause pancreatitis, right? You know, lipids of triglycerides of over 500 and 1,000, those sorts of things. Diabetogenic, arthralgias, affect sperm production. You can get a thrombotic microangiopathy similar to calcineurin inhibitors. You know, diarrhea, pneumonitis. You can see, again, a large list of possibilities. I would say the most common things that you'll see is the edema. That's not universal, but very common. You know, think of it as common as when you put someone on amlodipine. Okay. And often it can be pretty hard to manage. All right. Again, there is a decreased risk of malignancy, perhaps because of this, again, affecting mTOR pathways, right? Cell cycle progression. Also, perhaps by antagonizing the pathway of VEGF, which is presumably important for, you know, cancer to grow and metastasize. So people have done randomized trials with the use of mTOR inhibitors in transplant and shown clear documentation of less skin cancer. So that's not just an intuitive conclusion. That's proven by data that there's less risk of malignancy with mTOR inhibitors. Okay. All right, let's move then to co-stimulation blockade, belatacept, okay? Belatacept, again, would be considered, the opposite of these PD-L1 inhibitors in oncology, right? These uh, immunotherapies, right? Those are basically doing the mirror image of what belatacept does. Belatacept engages with the co-stimulation pathway and says, you see non-self, don't react, okay? But in cancer, they say, you see non-self, kill that. Okay? So same pathway, but different direction. So belatacept is this, let's call it a hybrid molecule. It takes a portion of IgG, binds to this CTLA4, okay? That is a molecule that engages with these receptors on antigen presenting cells, okay? And then there's a T cell interaction with that antigen presenting cell as well, okay? So again, the sum total of this is to say, okay, you see non-self, but don't react, okay? Tolerate that. Belatacept is typically given on this dosing schedule. Eventually you get to once a week dosing, but you can see that up front, you're giving it initially every 2 weeks, and then you go to weekly thereafter, okay? Sorry, monthly thereafter, all right? The advantages in a randomized controlled trial in lower risk patients, including another sort of, let's call it spin-off trial, that looked at outcomes in what was then called extended criteria donor kidney. These are these high KDPI kidneys. Hopefully you remember what that means. Those are lesser quality kidneys, right? Showed better long-term allograft function, okay? Defined by GFR, all right? So better GFR because you're avoiding some of the vasoconstrictive effects of calcineurin inhibitors that cause drops in GFR. There's less dyslipidemia, less diabetes post-transplant, okay? Those are all proven by these, the acronym is BENEFIT, okay? That's the acronym for the studies that were done in comparing calcineurin inhibitor as standard therapy to co-stimulation blockade as an alternative to calcineurin inhibitors, okay? But those same studies also showed an increased risk of PTLD, okay? Especially CNS PTLD, okay? In fact, it is now contraindicated if you are seronegative for EBV. Okay, the presumption is, remember, PTLD is typically driven by, not always, but typically driven by EBV. Most of us in this room have EBV latent in our body. Much of that EBV is integrated into our genome even, okay? And so immunosuppression allows for, let's say, breakthrough replication and transformation of your immune cells into uncontrolled dividing cells. Okay, that is PTLD. There's an increased risk of rejection. So clearly, belatacept is a less potent immunosuppressant than cyclosporin is. There's an increased risk of acute rejection. At 1 year, it was 20%, as opposed to less than 10% for cyclosporin. And there were also higher grade rejection episodes. That being said, these rejections did not clearly result in more allograft loss. Okay, so those rejections, when recognized early, are typically reversible. Okay, remember I told you, I think I'll make the point a little bit later, but I'll anticipate again. Rejection is not great, but it's not necessarily the end of the world, right? Seeing non-self, but rapidly reversing that can shift your cells to say, okay, I saw non-self, in the future, I'm going to be well behaved. I'm going to tolerate non-self. Okay. So again, rejection isn't always terrible for long-term allograft function when you can recover the allograft function back to near pre-rejection serum creatinine. Briefly, leflunomide is used very rarely in an immunosuppressive regimen. It used to be having more enthusiasm when you developed BK nephropathy in somebody who also had a risk of rejection or prior rejection. Okay, it's sort of a way to have your cake and eat it too, theoretically, because leflunomide is an antagonist of DNA and all.
Hey, Dr. Sam. This is Yassine. We can't hear you on Teams anymore. Your audio just went off.
Maybe I,
I
let's
heard
see.
you there for a second.
Yeah, there is going to be
I can hear you now.
Hey, mic check. Yep. Can you hear me?
Yep, I can hear you.
Okay, sounds good. All right. So, did you hear a conversation about leflunomide?
Yeah, leflunomide was the last thing I heard, and then it went off after you started patient allograft survival.
Okay. All right. So let's backtrack briefly. Remember again, as a generalist in nephrology, you need to be able to counsel about the pros and cons, the big picture pros and cons of transplantation. And certainly the biggest picture is, well, how likely am I to survive post-transplant compared to staying on dialysis? You have to be able to counsel that, you take on some extra risk when you undergo transplant, the surgery, the immunosuppression. And so for the first half of the year, if you're a well patient, if you're a healthy patient, you actually have a higher risk of passing away post-transplant. But after that, you get a survival advantage compared to patients who are staying on dialysis. Okay. And if you're a sicker patient, like a patient who is receiving a high KDPI kidney, you need longer time for that return on investment to be realized. I think in the previous discussion, I said lines intersect at around 12 years. That's a mistake. 12 months. You can see that it's closer to 2 years now that I'm reading my own notes when those lines cross in a typical high KDPI recipient. Okay, now you can have a healthier patient who chose to take a high KDPI kidney that might have survival advantage that is realized more early on, but these are averages based on the typical phenotype of patients. Okay, now here's an important point as well to make. This is, I think still reasonable to understand as a generalist, not just a transplant nephrologist knowledge. You might need to be able to help your patient navigate the question of, do I want to list for a high KDPI kidney? Okay. So a patient might say, well, they tell me the high KDPI kidney on average lasts half as long as a standard kidney. Why would I want to take that inferior kidney? Well, if you play it out and see what outcomes are evident in the data, the data shows that if you're an older patient and in your organ procurement organization, in your general, let's say, donor service area, your geography, the wait time for you is going to be around 30 months or greater. Okay. There's a statistical advantage to listing for a high KDPI kidney. Why? Well, you would be on dialysis a shorter period of time, and being on dialysis a shorter period of time correlates with better survival post-transplant. Okay. Let's look at the other side of the coin. If you're a young patient, right, with, let's say IgA nephropathy, with no other comorbidities, right, you're 40 years old, okay, and the wait time is going to be, 4 years, you should tell your patient, probably don't want to go listing for a high KDPI kidney, okay? If you're a 55-year-old blood type AB patient, where the wait time is going to be pretty short, right? In this area, less than a year. You might say, you may not want to list for a high KDPI kidney. It's your choice, but it looks like there's not going to be a clear advantage in that scenario. Okay? So those are how you're going to play this out. Okay? Again, this is, the survival advantage when compared to staying on dialysis and accumulating the morbidity of uremia, okay, or imperfect metabolic control. Okay. There are comments that one can or counsel that one can provide with respect to graft survival. Okay, so the fact of the matter is that we can see 1 year when your patients are going to ask you, what are the expected outcomes after transplant? You could say, well, 90% of patients who receive kidney transplants from a deceased donor are going to keep chugging along after 1 year. Okay. Certainly that's for deceased donor kidney transplants. Okay. Certainly there's a better 1 year survival for living donor kidney transplants. Okay. You can also ask your patient if they want, or if they're data driven. Every institution has to provide their 1 and 3 year outcomes. It has to be posted on the walls. So you'll see in the transplant clinic, once you go there, look for it. In the patient rooms, you're going to see these 1 and 3 year outcomes that are posted on the walls. Those are how programs are judged in quality. Okay. And you might honestly see a little, I think, different attitude in how hard to push to save an allograft in those first 3 years. I think that has to be, honestly conveyed. Okay. And if you want, to convey more longer term or intermediate term outcomes for your patients, here are the data. For living donor kidney transplants and deceased donor kidney transplants. Another way to convey it, which is perhaps a little less intuitive, is to convey it as a half-life, right? After 12 years, half of living donor kidney transplants are no longer working. Half are working, but half are not working. Okay, and that compares to deceased donor kidney transplants of various quality based on their high KDPI, based on their KDPI scores. Let's look at this in particular. These are, let's call it your standard run-of-the-mill kidneys, this KDPI 21 to 85. So you can say a half-life of around 10 years. Okay. And the high KDPI kidney, you can see, has a half-life of only 5.5 years. That's where that outcome. Let's keep that snoozing. Let's keep that outcome in mind too. That's where you're telling me this high KDPI kidney only lasts half as long as a standard kidney. That's expressed in this half-life that I'm providing you. Okay. Things that are relevant, that affect graft survival, that are dependent on donor and recipient factors are provided below. Okay, so donor factors, older kidneys, higher cold ischemia time. What's considered high? This also sort of helps you consider, well, when do these kidneys get turned down? Really, once you're getting over 24 hours, those are times where, people are strongly considering saying, the cold ischemia time is too much. But, you can accept kidneys even beyond 30 hours, right? If it's a young kidney. That would be pretty unusual, though, once you get over 30 hours. But again, those are things that can affect the long-term allograft survival. Okay. We talked about the DR mismatch, right? And so you get extra points for matching at DR. We talked about the B mismatch, but we said this was taken out of the allocation schema because it adversely impacted African Americans. A donor kidney from a Black donor, diabetes and high blood pressure, or high blood pressure in the donor, these intermediate cold ischemia times, those also seem to have a detectable effect on allograft survival. This death by CVA, okay, so you'll recognize that determines the KDPI of a kidney. These CNS insults factor into the KDPI calculations. And again, even not just 2, but even 1 DR mismatch seems to have some effect on kidney survival. Recipient factors, right? These are factors that also might help you further counsel about shortening your time on dialysis by accepting a high KDPI kidney. That's what this sentence refers to, okay? Some things about your recipient that affect graft survival might further enhance the survival advantage of a high KDPI kidney. So these are the recipient factors, right? I said that just being 50 with a longer wait time of over 30 months might be something that tilts you towards high KDPI kidney. But if you're a diabetic, if your age is over 60, Black race, multiple anti-HLA antibodies, previous transplant, long dialysis vintage. These are also things that might sort of eke you towards or nudge you towards saying, okay, high KDPI kidney to shorten my wait time in order to enhance my allograft and patient survival. Okay? So again, dialysis vintage, certainly this has been shown in data that the longer you're on dialysis, 1 year versus 2 years, 2 years versus 3 years, 3 years versus 4 years, the worse allograft survival post-transplant, okay? There seems to be no difference between preemptive transplant and being on dialysis for just 6 months, though, okay? Moving to allograft dysfunction, if we're ready to do that. Okay. Oh. I guess I have a hard stop. Maybe. All right. We're trying to take away a computer about to restart warning. I may not be able to. It looks like we're counting down from 10 minutes. Okay, so immediate allograft dysfunction might be caused by a variety of factors. Okay, so we're going to capture those, right, in this next discussion. Let's define allograft dysfunction. Okay, you are able to use the label DGF if you require dialysis after transplantation. Some would say acute kidney injury or allograft dysfunction that doesn't meet that criteria of needing dialysis. Some might call that slow graft function. Okay, that's a informal term though. Okay, DGF though is an official, let's say, reportable event for the transplant center. If you need dialysis after transplant, then that is defined as DGF. Okay, what are the risk factors for DGF? Longer cold ischemia times. Okay, donor after cardiac death. Okay, what is donor after cardiac death? Well, that's when you have a patient who doesn't necessarily meet criteria for brain death, but is dependent on the vent and or other invasive support, and the decision is made to withdraw that support, okay, even though there's not official definition of brain death. And so before the organ procurement can start, you have to basically disconnect the patient from the vent, confirm that they stop spontaneously breathing, and that the heart stops. Okay, and so there is a built-in, what we call warm ischemia time, where the kidney is not on ice, but is ischemic. Okay, it has no circulation. That's warm ischemia time. So DGF can happen in 50% of these DCD transplantations, okay? But allograft survival seems to be just as good as the standard procurement of a brain dead donor. Again, warm ischemia time is not good. We try to keep warm ischemia time down to 15 to 30 minutes. But once you start getting into this, 45-minute to hour range, that's really pretty problematic. Okay, so warm ischemia time refers to the time that you've cross-clamped and until you flush the kidney with cold preservative solution. Okay, that's your warm ischemia time. Okay, high KDPI would be a risk factor for DGF, not unsurprisingly. A sensitized recipient, right, because they can develop an early rejection. Dialysis immediately before transplantation seems to also be a predictor. But the way we navigate that is, you'll see patients that are dialyzed pre-transplant, but you leave them a little hypervolemic, right? You try to avoid them going into transplant perfectly euvolemic or hypovolemic. So that's the strategy that is often used when you dialyze someone pre-transplant. Okay. There is a decrease in DGF in patients that are put on or donor kidneys that are put on the pump. Okay, they're taken out of the donor and they're actually put in a machine instead of just you flushing with cold preservative solution and putting it on ice. They're actually put on a machine where it's pumping preservative solution through the allograft. You can monitor parameters and the surgeon can make decisions based on those parameters of how good the kidney is. One test is how much vascular resistance it has as it's pumping cold preservative solution through the allograft. Okay. We can evaluate the patients post-transplant. We like to see immediate urine output. If you don't see immediate urine output in a living donor, some would say don't even do the post-transplant ultrasound. If you start having a drop-off in urine output in a living donor kidney, that's a pretty concerning picture, and you should perhaps even take them straight to re-exploration, looking for some anastomotic dehiscence of, the ureters, spraying urine inside the peritoneum, or you have more ominously a vascular complication like acute venous thrombosis. Okay. Most people post-transplant, however, get an ultrasound with Doppler. You can use a parameter called resistive indices as one tool in your clinical decision making. A resistive index is essentially trying to measure indirectly the resistance in the blood vessels of the kidney. It is determined by the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. Okay, you want that number to be relatively low. Okay, when you have high vascular resistance in the kidney, like a patient who has ATN, where there's a lot of, let's say, or you might even say there's edema in the kidney that's causing increase in vascular resistance, right? In that scenario, you'll have a high peak systolic velocity, right? You're having a heart pump blood into a vascular tree with high resistance. So you'll see a pretty big peak, right? The diastolic pressure might be, low in that kidney with high vascular resistance. So that would be a scenario in which you might have, again, a high resistive index. Okay. So think of this again, high peak systolic velocity, low diastolic pressure as a classic scenario in which the vascular resistance in the organ is high. You might see that in an edematous injured kidney, such as a kidney involved by ATN or rejection. Okay. You would also have, relatively low diastolic flow, right? If I have an outflow problem like renal vein thrombosis, that would be a scenario in which I'd have low diastolic flow as well. So high resistive index. Obstruction might also cause sort of an edematous kidney and low end diastolic velocities. Okay. We also interrogate patients post-transplant with immediate allograft dysfunction or early allograft dysfunction by looking for urinary leaks through renal scintigraphy. That also gives you an indirect measure of intact renal perfusion, right? If you have a vascular, arterial compromise, your kidney will not light up. So scintigraphy can tell you something about perfusion, but is usually used to look for leaks of urine post-transplant. If DGF lasts longer than a week, most centers will say, let's biopsy this patient, looking not just from ischemic injury, ATN, but rather for a early rejection. Okay. Early or etiologies for DGF include ATN from that ischemic insult, calcineurin inhibitor toxicity certainly can be a cause for this. You need to be able to recognize in true life as well as in tests the histologic features of calcineurin inhibitor toxicity. That includes isometric means similar sized, vacuolization of the proximal tubular epithelium. So this is an example of this isometric vacuolization. It is not specific for calcineurin inhibitor toxicity. You can see this with other injuries, including high osmolar loads. And then nodular hyalinosis. Okay, that's this sort of nodular appearance of the intimal and vascular or the media layers of the vessel. And you can have thrombotic microangiopathy or just ATN. Okay. We're about to be kicked off here in this room. I think we'll end it there unless anybody has some questions.